All right, first intro. Jessica Bento. She's the Director of Operations for Innovative Fitness Solutions and Ultimate Sandbag Training. She heads up the educational programs for dynamic variable resistance training. She's a physical therapist and has worked in every aspect of physical therapy, including sports rehab, inpatient neuro, and geriatric populations. Josh Henkin is a strength coach. He's the CEO of Ultimate Sandbag Training and the creator of the Ultimate Sandbag and the Dynamic Variable Resistance Training System. He's been teaching continuing education programs for over 15 years all over the world and has consulted and created programs for all populations, everything from the military to Division I programs to hospital wellness programs. They both speak on our summit tour, and we are very happy to have them back doing another webinar. Josh Henkin and Jessica Bento. Thanks.
Thanks so much, Aaron and Chris. We really appreciate it. And guys, these opportunities to be able to share, information with you guys is so awesome, both for us and hopefully going to be practical use for you guys. But also just remember, we get these opportunities because Perform Better gives these platforms and chances to sort of, share this great education. So whenever possible, please support Perform Better so we can continue to have these great educational opportunities. Obviously, we're going to hit a topic today I think is relevant to pretty much everyone across the board in some form or another. And we have so much we want to do. Let's get right on into it. We're not going to spend a lot of time introducing ourselves because, Aaron did such a great job already doing so. I just want to highlight the fact that you're going to get the perspective both from Jessica's clinical perspective, and right now she's at her clinic that she heads up, and in my strength conditioning and fitness side, and I'm going to be here with our dogs, so it's like we're on equal ground here. So I want you guys we're getting both sides of the industry, and this information is going to be applicable to both.
All right, so I don't want to bore you guys too much with low back pain stats because everyone knows these stats and how prevalent low back pain is, but we have about 80% of the people that are going to experience low back pain at some point in time. And I'm sure a lot of you guys tuning in are experiencing low back pain yourself or working with individuals with low back pain. And we spend a ton of money each year on back pain.
Usually very unsuccessfully. And, stats can make things feel very kind of cold and hard to relate to. But for us, low back pain has been a big part of my life for the past almost 36 years now. I've battled back pain in many forms, having a very aggressive degenerative disease. I've had 8 spinal surgeries on my back. So I can relate to a lot of the challenges that people go through. So what we want to do is give you guys more of the perspective of hope, what works treating the whole person and not getting so fixated necessarily on pain, but bigger things that can make a more profound impact upon people that are struggling with low back pain, whether it's yourself or the people that you're trying to help.
Now, this might be one of the most surprising low back facts that most low back pain is non-specific, and that's 80 to 90% of people that experience low back pain. It's non-specific, meaning that there's no structural issues going on, no pathology causing pain. And that might be surprising because that's the majority of individuals that are experiencing low back pain, that we can't really pinpoint an exact cause as to why this is happening. And understanding chronic low back pain or that non-specific low back pain, which is the majority of what people are experiencing, again, means that there's no fracture, no tumor, no infection, no disc herniation that, correlates to a lot of their symptoms. So yes, you can have bulging and disc herniations and things like that, but it doesn't necessarily mean that that's the cause of your pain. So this is what the majority of people are experiencing, and this tends to be greater than 12 weeks. So it's usually the people that are experiencing low back pain. They come in and they say, I've had back pain for years and years and years. This is kind of what we're looking at with the majority of people.
Now we got to be very careful not to make these people feel dismissed knowing this information. We'll go over that because this doesn't mean the pain's in their head. The pains can still be very real. And just because it's non-specific doesn't mean it's not related to influencers like soft tissue issues, strength and mobility issues. Those aren't typically considered in the specific realm when we're talking about non-specific pain.
Now, I wanted to put this slide up here too, because athletes, high volumes of athletes experience low back pain as well. And oftentimes there's this narrative around low back pain where, if you're just strong, if you have good athleticism, you're not going to experience low back pain. But athletes experience low back pain quite often. And there's a ton of different influencers when it comes to why they have back pain, such as training load, fatigue, recovery, all of these things as well. So it's not necessarily a strength issue. And I think there's a narrative on social media and all throughout that. It's just, you got to get stronger. And that's, the fix for your low back pain. And there's another narrative. I keep hearing this over and over again, is that all of these people are getting unnecessary surgery percentage, 1 to 2%. Now remember, 80 to 90% of the people are going to have chronic or non-specific chronic low back pain, meaning no structural cause. So there's nothing to perform surgical intervention on. So everyone getting low back surgeries, that's not a thing. It's a very small number. And I work right alongside a surgeon. I can tell you the majority of people walking in are not going to have surgery.
And this is something not only do physicians understand or, is in the literature, but also insurance companies understand as well. And they're not going to allow people to often get any type of surgery until they do many other forms of treatment that are usually the first line of treatments for a lot of chronic low back pain.
Now, most low back pain improves naturally. So this is the statistics that is well known. Insurance companies know it. Around 90% of the people are going to recover within 6 to 8 weeks when you have like an acute injury to your low back. You're at the gym, you hurt your back. 6 to 8 weeks later, you should have resolved symptoms. And that is the majority of the cases. And I know people, like as soon as they hurt their back, they want to do 1,000,001 different things to, get out of pain and feel better. Or they think they need to be doing all of this work to heal themselves, when your body will just heal naturally on its own in 6 to 8 weeks. But it doesn't necessarily mean that this isn't going to turn chronic in nature either.
Yeah, and I think it also speaks to the narrative when if you hear someone say, "Hey, did you just hurt your low back? You got to do these specific exercises." No, you don't. You need to do movement as tolerated. You need to keep physically active. What happens when you do all these things to try to combat the injury is that you invoke fear, and you'll learn how fear is actually a major driver to the pain experience that many people have.
Now, chronic low back pain, which we've kind of discussed briefly, really, it's that 12-week or longer. It's majority of people are going to say they have back pain for 10 years, 20 years. I hurt my back when I was 20 and now they're 60 years old. It's that type of pain that you kind of see rather common in general population. 20% of the people that have that acute low back pain, the one that I talked about that doesn't resolve in 6 to 8 weeks, might turn chronic in nature, but it still doesn't mean that there's any structural or pathology involved with that. It's just chronic in nature.
That's going to be really hard because people often like to latch on to a diagnosis and they will run with that. And it's very hard for them to understand that there's something else causing the pain other than structural issues.
So there are a list a mile long of potential causes. This is just a really short list. I just wanted to put this up there because I think people get so focused on finding the exact cause, especially when it comes to low back pain. And there can be many, many causes, and sometimes we can't pinpoint exactly the cause. I just don't want people to get too caught up because I think people with, whether you're a clinician, you're trying to find the exact diagnosis, or whether you're a fitness professional or a trainer, that you're just you spend so much time trying to pinpoint it, and it can be many, many different things. Obviously, we want to rule out some major things, fractures, tumors, things like that, but oftentimes it doesn't change what I'm going to do with that individual. The diagnosis often doesn't dictate a whole lot of what I'm going to do when it comes to exercise prescription and what we're going to talk about more today.
It's so easy to try to think it's only things like discs and vertebrae and ligaments. I had a good friend who was having horrific back pain, and I tried to help him. He tried to help himself. He's a great coach. Couldn't get him better, and only to find out after he went some more imaging that cancer he had had before had come back, and there was tumors in his spine. So I don't do that to scare people, but I always do it to keep an open mind that we do kind of want to eliminate kind of red flag things before we get on to other things that we could be doing to help people.
All right, so like I said, a lot of things can influence back pain, and often as working with individuals, we don't have a ton of control over some of these variables, but sleep issues, if we're not getting good sleep, that can elevate pain. Stress, we all know that stress can increase pain levels. The work that you do, whether there's stress in your work or there's heavy lifting or poor postures and positions, sedentary lifestyle, living in a larger body, there's just so many factors that all contribute to something like chronic low back pain.
And the tough thing about all these factors is many of them are what are known as bidirectional, meaning that, for example, sleep. Well, poor sleep can exacerbate low back pain, but also we have research that people who have insomnia are more at risk for developing low back pain. So sometimes it can be hard, the chicken or the egg, or understanding that people may become more sedentary because they're in pain, and that could also exacerbate their pain levels. So you have to think about this in a bit more nuanced, holistic type of approach.
So hopefully you guys know this, but I have to put this up here. You should not rely on social media when it comes to pretty much anything when we're talking about healing and moving and feeling better, but especially around low back pain. There's just not a lot of good research out there, a lot of good evidence on a lot of the posts that you guys see. Most don't consider individual needs, lacks good evidence. That's more than half of what you see out there. And a lot of times it's not from any individual that should have a ton of knowledge on these topics as well.
Now, Jessica and I are obviously on social media and we're giving advice. So we're not telling you and we're not being oblivious to social media is something that you're going to utilize. But what we're trying to do is encourage you that if you are finding something on social media that does seem kind of like it makes sense, something you want to follow, do a much deeper dive, read the actual research, go in to see what the literature actually says for itself, because there's a really bad trend now where people will flash up a study and say this study, and they won't actually accurately reflect what the study found or what the limitations were or really what the study was representing. So you always have to be a good filter of information when you're using social media. And I consider it more of a guide to point you to certain directions to learn much more about a specific topic.
And that goes, for all platforms, right? So it does not generally reflect contemporary evidence-based practice. And that's across the board with any platform. So just be really hesitant, the advice that you're taking. I see so many people just take information that they see that same day and then apply it to their clients or apply it to their patients. And they're not really diving into the whys behind what they're seeing or with the advice that they're given.
Yeah, it's really disturbing to see that research generally shows the more popular an account or a topic is, usually the less evidence is behind it. So again, you just have to be a skeptical, consumer of information. Doesn't mean don't use these platforms. It just means be a good consumer of the information that you're doing and make sure you do your homework on anything that you're thinking about applying to other individuals.
All right, so we're going to talk about a few myths. I've used this slide before in the past, but I think it's worth bringing up because it's starting to come about more and more. Like I just saw, I think Dex Shepard, whatever his name is, on his podcast. He was
Kristen
talking about
Bell's husband, that's what we call him, right?
That's what he is. He was talking about it on his podcast, and everyone keeps, talking about the study. It's an actual old study. It was looking at relatively healthy individuals that had no complaints of low back pain, and they did MRIs of all of them. And what they found is that pretty much all age groups were starting to show signs of degenerative changing, like disc bulges, herniation, stenosis, facet stuff. And so a lot of times people are using this study and saying, see, imaging is just fear mongering, right? Because all of these people were perfectly fine. And then they got this imaging and there's a bunch of stuff going on. And now they're probably going to be afraid. And there's this, narrative around pain and movement. And that's not what imaging is for. It can be very valuable and should really guide informed decision making. That's what's important about it. I really find imaging helpful for education. So I get to sit down with a patient and really talk to them about its findings. So if something shows up that, is normal degeneration or normal wear and tear, we can have that talk and say, you're normal. This is totally, with that aging process and there's nothing to fear. But if they don't have that talk, if they just get sent home with that imaging and it shows all of this stuff, but, maybe the doctor knows that there's nothing major going on, they start to have this belief or this fear, like I'm broken. I shouldn't be doing a lot of stuff because my spine is damaged. That nocebo effect where we start to see increased pain if they're not well educated on what their imaging finds. I spend an enormous amount of time sitting down with people, going over their MRIs, going over their imaging and talking to them to kind of calm their fears about what's going on.
Yeah, it's perfectly fair to say that there's doctors that aren't good communicators and our healthcare system's kind of broken and they don't get a chance to spend enough time with patients to do that education. But, imaging in of itself is neutral. It's neither good nor bad. It depends upon the context in which you use it and the education you put behind it for people. So again, trying to scare people into not getting imaging is almost just as bad as what you do with imaging. So again, if you have a client that comes in and is confused, they've heard these big words, don't know what they mean, it's a great opportunity for you to also give a little bit education. Like, did your doctor sit down to you and tell you what stenosis means? And did they say that it was actually reflective of the damage or the discomfort that you're feeling in your back or maybe down your legs? there's a little bit of the telephone game too, and I know Jessica knows this all too well, of what a doctor tells a patient and then what the patient or the individual tells you at the end of the day, because they may not understand all the verbiage and words used to communicate what's going on in their body. And they get fearful, they get stressed, they get frustrated, and they may not actually reflect what was actually told them by their physician.
Now, this is a big one as of lately. Everyone is talking about loaded spinal flexion, lifting with a rounded back, or lifting with flexion. So many people think that just one time bending over or lifting with a flexed back is going to cause instant injury. And for some, it may, and for others, it's not. But you can't say flexion in and of itself is going to cause an injury. So this needs a lot more clarification and a lot more nuance. And these are some of the studies that have been thrown around social media lately. So we really wanted to kind of talk about this. Now, how much lumbar flexion actually occurs? So what people fail to mention when they show a study and they go, look, lifting with a rounded back causes no pain. And then they show an exercise, and I'm going to use a Jefferson curl so you can visualize how much spinal flexion that exercise takes. It's actually only about 36% of the available lumbar range of motion. So it is not that much range of motion what these studies were looking at. It was not full lumbar flexion. It was not full spinal flexion. It was very minimal what these studies looked at. But then they'll take that study and say, see, we should be doing all of this.
Yeah, I think people make the false assumption that more must equal better. Number one, it doesn't say that it helps low back pain. That's important to know. It just said it wasn't an obvious risk of low back pain. And then again, more could be a higher risk of low back pain, as we'll discuss.
And so what they failed to mention as well, so not only the range of motion was much smaller than what they show in a lot of the exercises, but the load. So I want you guys to understand all of these studies that people are showing about loaded flexion, lifting with a flexed spine, lifting with flexion of the lumbar spine, less than 26 pounds. Very, very light loads, like light boxes. That's what was used in these studies that are getting shared and shown all over social media. So much, much different than something like a heavy barbell fully loaded and going into full spinal flexion, lifting under heavy loads. So there really has to be a discussion about it because it can be very misleading and people will misinterpret a lot of this research.
Yeah, oftentimes people are pushing their own narratives and misrepresenting what the research actually showed and indicated. And so, there's some fair criticisms to have. And the big study that everyone signs to point to is a review, a meta-analysis that was the flex or not to flex paperwork. And so if you do look at actually some of the criticisms of this actual paper, because all papers have criticisms, one is that most of the studies they reviewed were relatively low quality, right? So again, we can look at was there a causation correlation issue in a lot of these different studies? And again, a lot of the studies couldn't make definitive claims on causality. So hopefully a lot of you are more familiar now. I know it's gone around, the correlation causation fallacy. It's like the old adage that both ice cream consumption and shark attacks go up during summer. So therefore, eating ice cream increase shark attacks, right? Well, that's a correlated effect. It's not obviously causative. So we always have to be careful in a lot of these different things to make sure that we're looking as a causality or correlative type of things. And then again, lumbar flexion was not measured the same way every time. When you're looking at meta-analysis, you're looking at studies that look at many other studies. So these other studies could have looked at, examined, and used different levels of flexion when we're looking at what was actually performed. So again, it didn't look at issues like what actually caused pain. So again, you can't do a study, and this is where I think Jessica can back me up on this. You can't ethically do a study, we're going to do this until you hurt yourself. This is where people make irrational arguments online like, well, no one's ever shown that if you do this, that you hurt yourself. You can't do that type of study, right? You can't take 50 people and go, we're going to do this exercise until we actually evoke back pain. That's not something that's going to be allowed for. So again, you have to understand how people are sort of looking at this, the assumptions they're making from the information they're doing. And oftentimes the studies that they looked at were actually very short in term, whether they were a single session or a very minimal amount of weeks. They didn't look at this over a cumulative period. So they didn't look at people that were doing this as an occupation. They didn't look at people that are doing under fatigue. They didn't look at other variables that can definitely play a role in whether or not people are at a higher risk of having low back pain. So even one of the people that wrote the paper that everyone loves to cite said, hey, if you're talking about doing things in a workplace environment, guess what? We should keep the loads close to our body. We should reduce the chances of doing things that might cause injury in our body. So they weren't necessarily proponents of saying, oh my God, you should do this. You should lift with a flex spine. They were just saying that we may need to reevaluate where if spinal flexion is the main driver in many of these cases of driving low back pain, but there's also obviously multiple factors we have to consider. It's just not one thing. So we can reduce the fear of someone that maybe is afraid of bending down, that they're going to blow out their back, say, you know what, it may not be a high risk, but there's other things we actually have to be prepared to discuss as well. So again, a lot of times people say, well, we don't have studies looking at to see if rounded back postures, do cause problems over time, especially in real people. Well, that always tells me people didn't actually look for research, because we have lots of research on people in different occupations and whether or not they load their spine when they do certain activities. So for example, this study looked at automotive labor workers, so people that were putting together cars, and they found that this is a repeated effort type of thing, they're under a good amount of load, there's fatigue that obviously comes over time, the people that use their low back more to do some of the lifting were over 2.5 times more risk than people that had less flexion in their spine doing the same job. So we can say that maybe there's a cumulative issue of people lifting with a rounded back posture. So again, the more you used your back, the more people were at risk of having low back pain over the long run. That seems like a good reason maybe to encourage people not to lift with round backs. We're not running around with our hair on fire. I don't have any left to tell people like, oh my God, you did 1 rep with a round back, you're going to die. That's not what we're suggesting. We're just encouraging people into habits that are better for their safety and long well-being. Now, this was also another study that looked at automotive labor workers, and what they found was also, again, what's going to take us into another aspect, that it wasn't just the loads or the fatigue or the flexion of the spine that played a role, but it was also how much stress people felt in their job. So those that had higher levels of stress in the job actually were at more risk than people that were still flexing their spines but didn't feel the high stress or felt more in control of their everyday job. So this starts to take us into the fact that physical stressors, physical factors are not the only things we have to consider when we're looking at why do people have low back pain.
Now, I have to quote Josh.
I love it. We should do it more often.
I've done this multiple times. It was just something that kind of came up in our morning coffee discussions. Like, if strength has a limit, why doesn't resilience? And I think we can all understand like strength, endurance, brute force, all of these things have limitations. But for some reason, when people bring up low back pain, the common, the quote is, well, your spine is resilient. It's made to move. But resilience has a limit as well, the ability to adapt and recover. It's not limitless by any means, but for some reason, when it comes to low back pain, people are constantly like, well, the spine's resilient, it's going to bounce back. It's kind of like this car. If you kick the bumper or the tire, obviously it's going to drive off and be okay. It's going to be resilient. But if you slam it into a car, I'm sure it's not going to be resilient and back out and drive away. So I'm not sure where that all came from, thinking that resilience was infinite. Now, again, everyone keeps saying the spine's resilient, and then they go do these crazy exercises, right? They do heavy loaded spinal flexion with rotation. And we've known for years and years and years and years what the potential causes of disc herniation and low back injury are coming from. And typically it's from heavy or loaded spinal flexion, a lot of repetitions, and that's what tends to cause that type of disc herniation or that pain. And I don't want you guys thinking it's just McGill saying that. It's study after study after study. We're going to talk about McGill in a little bit as well, but we've known this. So I don't want to put people in positions and postures that I could potentially, I'm not saying everyone is going to experience injury if they do loaded spinal flexion, but we don't know at what repetition, right? So we don't know the tolerance and capacity of a lot of people. We don't know the resiliency of the spine and at what rep or at what load we might hit failure.
Just think of it, that really cool video you see of the guy lifting like a heavy spinal flexion saying, I fixed my back this way. Number one, you don't know what his back issue was. Number two, you don't get to see him 5 years down the road. So these are things that you really have to think about is while it may be a lower risk for some people, you don't necessarily know if it's a higher risk for the person that you're working with. Plus, there's no evidence that actually this helps low back pain. And that's the big thing that I think a lot of people are missing. While it may not be always an inherent risk, it doesn't make people actually better either. So one of the things that can actually change, to Jessica's point about resilience, is not every bulge and herniation is the same. There's plenty of people that have bulges and herniations that are totally fine, and there's some that can be really problematic. You're looking at one guy here who lost complete use of his right leg because of it. So what they tend to look at is other factors of the structure that could be problematic, that could set people up to having lower levels of resilience after they heal. For example, did you have an end plate fracture with that disc bulge or herniation? Did you have significant disc height loss? Meaning that some people estimate if you lose over 70% of your disc height, this is going to lead to long-term changes in your ability to tolerate certain loads in the spine. So these are things that people often don't talk about. It doesn't become a hot topic on social media, but it's important to discuss and know about the client that you're working with, especially if you want to put them under high levels of stress.
That's another reason why imaging is rather helpful. Remember, I said it helps guide informed decision making. So if I see imaging like that, like Josh had just described, it will change my exercise prescription or what I'm going to attempt to try with an individual.
Yeah, some people that have those different issues are going to have reduced tolerance to repeated end range loading. They're going to have lower levels of ability to resist fatigue and less recovery. They're going to have greater sensitivity spikes to, again, these are people that might be more prone to having flare-ups. Also, it changes how they create stability. So generally, we think about stability as three different systems. We have a neural control, we have passive, which is the spine and all the structures of the spine, and then we have like muscles and ligaments. So if you lose one of these main systems, meaning the passive, it's putting a greater emphasis on the other two. And this can reduce people's tolerance and capacity to do certain things. It doesn't mean they can't come back to doing certain exercises or doing certain activities, but their ability to do it at a super high level or try to hit super heavy weights might be diminished. And that's something we need to consider if someone has actually experienced some of these different issues. So again, like Jessica said, sometimes people really misrepresent the science. People love to pick on Dr. McGill, and you know what? I think Dr. McGill would even say it's fair and he's open to having criticisms and discussions with him about his work, but it's not just the McGill that's pointing out to a lot of this information. This information has been well researched in many different forms, whether you're talking about biomechanical models, cadavers, or actual occupational real life people. So this is not just looking at one person. This is coming from the fact that a lot of people are online are trying to be contrarians so that you follow them and do what they say, and they'll ignore a lot of the research that says the opposite of what they're actually talking about.
Now, this is another one that people keep saying the spine needs a lot more mobility. That's why we're doing a lot of these flexion-based drills for when someone has chronic low back pain. But those who have more motion in their backs have a greater risk of having future back trouble. So it doesn't necessarily mean that mobility is the issue. And what we're seeing oftentimes when people come in, and obviously I see a lot of different populations that are in extreme pain versus what you would see at the gym, but what we're seeing oftentimes is a lot of muscle guarding and fear of movement. So it's not necessarily a mobility issue. They're just, all of those muscles are guarding that area, so they look stiff. They look like they're not moving that well. They're also afraid to move. And believe me, this is real. Kinesiophobia is real. I've seen it time and time again where people are just so petrified of moving or doing anything because they think they're going to hurt their back even more. So it's not necessarily a mobility issue. And one of the biggest issues when it comes to unresolved chronic back pain is instability. What we see oftentimes, and I'm not saying everybody, because someone's probably going to yell at me and say not everyone has an instability issue, but oftentimes there's an instability issue. And what tends to happen is that people like those MRIs, right, that showed that individuals that didn't have pain had all of this going on. They still might have some instability going on, but they haven't pushed beyond, those limits of their daily activities. They haven't done more than what's asked of their spine, so they don't really know at what point that they're going to hit failure or actually cause pain and discomfort.
Yeah, I think going back to that MRI study that you showed, Jessica, we know as people age, the level of degeneration goes up. So when you take someone who's coming in the gym the first time and they're 60 years old, I think of the grandma videos, and I think it's awesome that they're willing to strength train, but when people start putting them under max low deadlifts, you're really doing Russian roulette with people's spines, because this is maybe a load that they have not been introduced to progressively enough over time. And if they have some of these degenerative changes, and again, it's far beyond what they're used to doing, this is where you can develop issues for people with a lot of these things. That's not just deadlifting. It could be running and jumping. Like, we've known people that have gone to Gym Jess that are relatively fit people. They do box jumps, they do burpees, and they've fractured their spines. They've herniated discs. So when you start doing something significantly greater than you're used to doing without doing it progressively, you do increase your risk, right?
Yep. Now, when we're talking about range of motion of the spine, if you look at that chart there, the darker bar is the symptomatic individual. So people in pain versus people asymptomatic, not in pain. You see that the ones that are in more pain actually have more movement of those individual spinal segments. And this is just looking at extension. There was other charts in the study as well for flexion and so forth, but they actually have a lot more movement in those individual spinal segments. So they found no correlation between lumbar range of motion and low back pain. So when people keep saying you need more mobility, therefore you need to go into these excessive ranges of motion to get it, not the case. Now, what tends to happen too, so most of you guys know that spinal fusions are pretty much the main surgery that people get when we're talking about the lumbar spine, or the bigger of all of the surgeries out there. And what a lumbar fusion does, it fuses those segments together because we have instability at those segments. So that's the most common of them. So we have too much movement occurring. So to say that everyone needs mobility is just not factual.
And in fact, trying to get more mobility could cause people to be in more pain, depending on if they do have too much instability. So what should we be doing then, right? Okay, what should we do if we're saying this is not the way to do it and this is not the way to do it? What should we be doing? Well, when we look at actually research, a lot of the research keeps pointing us back to the things I think that a lot of people like to make fun of now on social media, Jess, which is a lot of trunk balance stabilization, segmental stabilization, and motor control exercises. And what they found is these things work. Amazing, right? And so I think this is where a lot of people, I think, just maybe you could talk about it. You see, even with clinicians, that they're starting to bash on these things. And we'll talk about where they lose a little perspective on it.
Yeah, if I see another post of a physical therapist, or if a trainer, anyone, you're like, oh, I bet you went to physical therapy and you did bird dogs and dead bugs and you did clams and all of those things, and your therapist doesn't know what they're talking about. This is a great starting point for people. It can be very challenging working with people in pain that are very fearful of moving. So these foundational core stabilization, trunk stabilization, motor control exercises are really helpful, not only to show an individual that it's okay and safe to move, but it's a good starting point for people that don't have good movement proficiency, don't have that ability to stabilize and do those more foundational strength training lifts that everyone thinks, oh, if your PT is doing clams, you got to get out of there and start doing heavy deadlifts. No, these exercises are very beneficial for people. I have people that are just afraid to do anything, but if I can show them that they can do these exercises, they're more apt to start doing more and coming more frequently and believing in their bodies that they're more capable of doing something, that it's safe to move. These are very beneficial exercises.
I think most people forget the number one fear of someone who's in pain and doing an exercise program is you causing them more pain. And so if you can show them that movement doesn't have to hurt, even if you consider it low level, which I don't necessarily do that, then they're going to be more apt to build that confidence and see they can exercise without building that pain. Now, I just want to stop here and pause for this slide because it's the greatest slide I've ever created in all time. I'm very proud of it. Anyone who's a Star Wars fan will appreciate it. There's a trap that a lot of people online make for their content, which is they talk about these exercises that Jessica's been mentioning and saying, well, it doesn't fix your low back pain, so therefore they're no good. If the standard was fixing 100% of your low back pain, guess what we should be doing? Literally nothing. Because there is no evidence of anything working 100% of the time for 100% of the people. Now, what we should be looking at things are what helps people, what restores function and confidence and all the things that we've been talking about. Funny enough, core stability training does a pretty good job of that, right? We see that people have pain reduction. They have reduced disability. They have improved function in things like walking and bending and daily activities. Now, the longer you do them, the more we see some of these results. You don't do them for a week and go, oh, I feel better now. But we do see improvements. And again, when we look at an analysis of it, we see a moderate to large pain reduction in things like stretching, right? People love to slam on stretching. And Jessica, you just saw a post of a physical therapist that said, I never stretch a patient. For certain people, it can be very productive. Now, the types of stretching is going to be individualized. Some people need assisted stretching. Some people can do more movement-oriented work. It just depends upon their level of pain, capability levels, confidence, and so forth. But to say stretching doesn't help is insane because that's not what the evidence shows at all. Is it going to 100% eliminate people's pain? No, but it can definitely be a great tool that we use in combination with other things to help people move and feel better. So when we look at studies, so this was an interesting study, and now granted, it was only on about 30 individuals, but they were 30 individuals with non-specific chronic low back pain. They found when people did the boring exercise that Jessica mentioned, like a bird dog, a plank, a modified sit-up, and curl up, they had almost an 80% reduction in their low back pain. Boy, if you took someone who had chronic low back pain and gave them an 80% reduction in their pain, you'd probably be their favorite coach or therapist, and they would refer everyone in the world probably to you. It's not 100%, but it's super significant. Now, what's also equally interesting is when the people did just basic things like dynamic back stretches and pelvic tilts and the chest exercise, they saw almost a 63% reduction in their pain. So again, I think what we're getting to in a moment is that there's no perfect exercise, but these types of exercise do help reduce people's pain, improve their function, and guess what? There's not any real side effects, assuming you work at this right level of progression of any of these drills. So there's a whole bunch of benefits and not a whole bunch of negatives. So I think that's what you have to do. When you think about that balance, the balance scale's like this, and yet people still love to slam on the core stability work because they expect it to be 100% reduction in pain, and that is a mistake in expectation. So again, when we look at the review literature, reduces pain, improves muscle function, improves disability and function. Now, here's the interesting part. The longer term we look at, it's not necessarily superior to just general forms of exercise. So again, it's not like it's magical, and it's not like the issue was necessarily core stability, because we see over the research, as we look over exercise over time, that general exercise and core stability kind of level out in the effects it has. But it's a great way, as Jessica mentioned, to build confidence, build body control and awareness. A lot of people believe, and belief is a big part of this, that if they improve their core, they'll improve their back pain. This can all help. I don't see a lot of negatives in this type of formula. So when we're talking about things like stability, I think people often think like we're trying to make people like mummies, and that we're just going to be really stiff, we're just going to be on plank all the time. And that's not what we're talking about. Yes, foundationally, people need to learn how to stabilize. They need to learn how to maybe brace. They need to learn how am I going to prevent unwanted motion from occurring in my body? But over time, the goal is to make it more what we know as reflexive, where we react, where we can have it turn on and off much faster. But everyone loves the analogy, you need to walk before you run. But many times in social media and in fitness circles, people want you to sprint before you take a step. So we have to learn some of these foundations to build up to these more advanced exercises. Stability is not being tight or stiff or not moving. That's just a part of the spectrum that we're working at, oftentimes in introducing people when pain is at a higher level. So again, we're not making 10 men and 10 women. We have to think about who we're working with. Again, what type of feedback do they need? A lot of times people struggle with body weight because body weight doesn't give them appropriate feedback to understand how to control their body in space. Body weight often requires you to already have reflexive stability because you're getting no feedback from any external implement. And our goal is to eventually make it where you don't rely on tension to create the stability. You can quickly react and create stability as needed, but that needs to be a systematic process. So this is the thing that I think Jessica and I were worried about. It's going to bum everyone out. When you look at the research, guess which type of exercise works best for reducing back pain? All of them. Literally no form of exercise is superior to any other form of exercise for reducing low back pain. Now, I know the reaction is, well, I'm just going to throw my arms up in the air. I guess what I do doesn't matter, right? That's not what it means at all. In fact, hopefully it should be actually really inspiring for you guys, meaning that you need to find people that like certain forms of training, can engage in certain forms of training, that you don't have to feel obligated to get them to do specific exercises. You don't have to get people to do this or that. You have to find what they feel confident doing, what they feel comfortable doing, what they like to do, and start there and slowly use graded exposure to things they might feel are a little bit scary, things that they might feel are a little bit more risky, and do it in a very progressive way to get them to reduce that fear of the movements that maybe they associate with having injury. So Jess, I don't know if you want to add anything to that, but I think, this is not a negative. This is a great benefit.
No, it's a huge benefit because I think everyone is thinking that they're not doing the right thing, or they're missing something, or there's something they're not adding in, or something they should be doing. It boils down, like you said, to find something that someone can do rather consistently for an extended period of time that they enjoy and they feel that it's allowing for improved function and mobility and all of the things that they want to be focusing upon.
So when you look at all these components in isolation, strength training, stretching, breath work, core stability, walking, individually, they're not very impressive in the effects they have on low back pain. But when you put them together, the impacts can be very profound. So yeah, we do want people strength training. It may look a little different depending upon the individual, but yeah, we want them to do it. Yeah, we should have people doing some form of stretching. It may not be a specific exercise or a specific form. It might be more generalized. Yeah, we can teach people breath work, but the cause of their pain is not because of their breathing. Oftentimes they're in pain and then their breathing gets altered, but we can use it as a way to calm down the nervous system. We can improve some core stability. You don't have to do a specific core stability exercise. You have to do the one person that the person can execute well. And walking has been shown to be actually a very valuable tool in helping reducing low back pain. So helping people get on walking programs can be very helpful, even if it's for 5 to 10 minutes on a more regular basis. How many times just do we hear people go, walking is not exercise? And that's like one of the worst pieces of advice that people can give.
Yeah, and oftentimes it's the most accessible exercise to a lot of people. And by hearing people say, "Oh, walking's not enough," or walking is an exercise, then they feel kind of defeated and they go, "Okay, well, I'm not going to do anything then."
So here's kind of the funny part. I know we're a little bit limited time, so I'm going to go a little fast. Most people don't even know what pain means. They know it hurts, but they don't know what it means. Like, what's the definition of pain? So I think a good, reliable place to start is the International Association for the Study of Pain. Pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Well, those are a lot of words. What does that mean? Well, pain is always a sensory experience, right? We're getting sensations. It's always also accompanied by emotions. So it doesn't matter. Even if it's structural damage, there are emotions that are associated with it that can drive and make pain worse or make it better. And pain itself is not a bad thing. Pain is a protective mechanism. There are people that do not have the ability to feel pain, and those people actually live a much shorter life. So again, pain is not necessarily a bad thing. We have to think of what are the drivers. What is it trying to protect us from is the question we really need to answer. Now, if that definition was a little bit much for you, I do like this one from Dr. Rachel Zoffness, who's a chronic pain expert. Pain is the brain's opinion of how much danger you are in. Now, I think this still gets people's heads to go, do the major blow up, because all pain, even structural pain, is created by your brain. Not your low back, not your ankle, not your shoulder. It's created by your brain. It's influenced by information it gets from the central nervous system, but it's also impacted by psychological factors and social influencers. So all these things the brain puts together to decide what to protect you from and how much pain to create. So how much protection do you need? So I love this quote from a personal trainer who does a lot of chronic pain work, Charlie Morrell: "Being strong might prevent injury, but it does not prevent pain." I always say injury and pain are two different things. And I've worked with enough surgeons that will also say, we can do surgery to help the structure. I don't know how much will influence pain, because they aren't the same thing. And I think we often get them confused. So the best analogy I hear is the one of the smoke detector, right? The smoke detector. So if I'm in the morning making breakfast and the smoke detector goes off. I don't know if I'm burning my eggs or the house is literally burning down. I don't know what's wrong. I just know something is wrong. And that is a lot of what's happening with pain. You don't know exactly what's going on, but something is going on that you need to pay attention to. So even if you have true structural damage that's causing pain, you have to understand that other things are also driving pain. Fear and catastrophizing. Oh my gosh, this pain is back. This is the worst pain I've ever had. Oh my gosh, I'll never get better. Oh my gosh, see, my back is out again. I knew I have a bad back. Are all representations of that. Social influencers. We know that work stress, relationship stress, financial stress, all those things can actually make people more predisposed to having low back pain. So you need to know, how is someone stressed? How is their work stress? How's their family stress? How's their financial stress? You don't need to know every single detail, but you need to know if these are influencing factors. We know social isolation is a major driver for chronic pain as well. So again, we need a more integrated approach. Yes, exercise is a valuable tool, but so is pain education, psychological support that we can help people relate to, gradient exposure, introducing things that people are afraid of in small doses, and stress management and lifestyle techniques, right? It has to be a more holistic approach. And this may sound like a lot, but in a day and age where I can go online and I can get a workout program, I can have someone tell me which course to be exercise to do. I can download the app, on my phone or my TV to do stuff. This is the stuff that's going to separate you to make you a valuable asset to your clients or your patients. Because if it's just about doing an exercise, I can find that on my own. I don't need you. So we also look at how this relation, works with things like, gaining weight and being overweight. We know obesity, chronic pain, disability, and psychological distress are all interrelated. And this drives me nuts in our industry. And I've been talking about this for years. We like to focus just on the exercise part and assume when people are overweight, that it's just a discipline or a motivational issue. It's not. One of the biggest stressors that people can have is chronic pain. Chronic pain will drive things like emotional eating, physical inactivity. It'll increase inflammation in the body. That will cause psychological distressors that, guess what? Cause physical, inactivity, emotional eating, and so forth. So if we actually want to help people, even with goals of losing weight, we have to take a more integrated approach. So we see that, again, chronic pain and weight loss is hard because people with chronic pain are less likely, less able to oftentimes lose the same amount of weight, even when they do, or they try to do the same level of interventions of people without pain, because chronic pain is such a stressor, it makes doing the lifestyle changes that much more difficult. So we have to start making things much more easier for people. We have to introduce concepts more progressively. We have to find things that people can do immediately and build success far sooner in their work. And a big cohort study found that even when people with chronic pain improved their physical activity, they improved their psychological distress, they actually weren't that successful in losing weight, at least initially. And that's due to that long-term chronic pain can actually physiologically change our bodies where it makes it harder to lose weight. So we may want to introduce other goals, like making sure hey, maybe your goal is also, I want to be able to do a 30-minute walk without having pain. Maybe your goal is, I want to be able to go out with my significant other or my friends and not worry about, being in a chair too long. Maybe it's being able to go back to a certain sport or hobby that you enjoyed, making it other than just weight, because this may be harder for people with chronic pain to achieve, especially if you put pressure on them to do more lifestyle changes that are already overwhelming themselves. So again, weight loss remains difficult because of many physiological changes: inflammation, insulin resistance, altered stress hormones, autonomic nervous system dysregulation, metabolic adaptations, and disrupted appetite regulation. So you need to see this, because that's the only way that we're going to understand what we need to truly address with individuals. It's so much less about your back and so much more about the person. And if we start changing and shifting our perspective, we're going to be able to doing such a bigger service for people than we originally have been able to do, including myself and a lot of my clients. And this research, I think, really highlights this fact. So Dr. Howard Schudmer, who's a chronic pain expert physician, he's published over 100 studies to do with chronic pain. They did a massive study somewhat recently, over 200 individuals with chronic low back and neck pain. They found 88% of those people did not have structural causes of their pain, that most of them were due to mind-body issues of stress, tension, and repressed emotions. So no wonder why people get frustrated with just doing exercise, because exercise is a small component of the overall plan we need to work with people in order to help them with the low back pain. So this was a really interesting study out of Northwestern. What they found were people with acute low back pain. They did brain imaging and saw that their brain imaging was reflective of acute injury, meaning that where they expected to see where the brain was most active was reflective of more that nociceptive, that sensory pain. But those people that went from acute to chronic low back pain, their brains actually changed. The brain actually changed where most of the activity started to be in the more emotional components or emotional aspects of the brain. So again, things are changing, not only, again, structurally with your body, but also with your brain the longer you're in chronic pain. Then this is because emotional and physical neural networks in your brain often overlap. We already know that a lot of times emotional pain can actually hurt, right? How many times has someone said this breakup actually hurts, right? Or the loss of someone actually hurts. It can actually physically hurt. We know things like headaches and migraines, neck and shoulder pain, muscle pain and tightness, digestive issues, jaw clenching and teeth clenching, chest tightness, low back pain, and fatigue and low energy often have a driver underlying of emotional distress. Now, we're not mental health experts, but there are definitely strategies we can teach people to deal with these things more effectively, and then possibly refer, when necessary, to people that can also help them with more of the emotional side. There's a study I've been, clamming on for years that I just don't think it gets enough. It almost gets no attention in the fitness industry, which is really disheartening. It was a study done published in 2022 in the Journal American Medical Association. I should have just said JAMA. It's so much easier to say. A very well-respected journal. They took over 151 individuals with chronic low back pain. Most of them were in pain for over a 10-year period of time. They gave them 3 different strategies. One was usual care, just like keep doing what you're doing. One was a placebo injection, so like a saline injection in their spine. And one was what's known as pain reprocessing therapy, which is purely a cognitive approach to pain. And what they found was that in the pain reprocessing therapy group, 66% of the participants in that 4-week time frame were pain-free or nearly pain-free. So people who had pain for over 10 years did this for 4 weeks, and almost 2/3 of them were pain-free or nearly pain-free. This turned the pain science world up on its mind. Like, people are like, oh my God, what the heck happened? And most of what pain reprocessing therapy teaches is safety, nervous system regulation, how to not, fear a lot of the patterns that we associate with our backs or other areas of our body, and to retrain our brain. This needs to be somewhere as a part of our program. So again, it's effective because it's targeting not the back, but the brain. And this makes people's heads hurt. And I'm not saying we can't use exercise. We can actually use specific forms of exercises like mind-body fitness to actually elicit a lot of these type of effects for people that may be a little bit more skeptical or maybe not be ready to fully dive into a lot of these areas, because people are coming to us oftentimes for exercise. But this is not new. Over 46 years ago, we had studies showing that mind-body practices were highly effective at reducing pain experiences and changing people's relationship with pain overall. So again, it's funny, we've just decided to ignore it for almost 50 years, which is really a disservice to people that are in chronic pain. So oftentimes we can tell if the brain is a big part of this by looking at what Dr. Schumer created what's called the FIT criteria. It's functional, inconsistent, and triggered. So again, we can see things like symptoms arose even when healing is done. So Jessica talked about most discs heal within like 6 to 12 weeks. If you're at year 5 and your doctor's like, there's been really no significant progress on your disc, well, it's probably a brain issue. The brain has just started to misinterpret what's going on. It's not that you're making up the pain, it's that your brain is misinterpreting what's going on. It's inconsistent. I think Jessica talked about this a lot. You had patients like, if they go on vacation, they don't feel their pain, right?
Yeah, it happens all the time. They're like, oh, I felt great. I didn't even think about it.
That's a telltale sign that it's a brain processing issue. Because if it was structural, you'd be in pain all the time. Triggered, if certain types of stressors or environments, like if you're fine, but the time that you start driving to work, your back starts killing you, that's being triggered because you're associating the work on an unconscious or subconscious level with stress, and that stress is causing that pain driver. So that we can look at these symptoms and use them as tools to help educate people about what is actually going on and why exercise is a component, but only a component of the overall plan. So again, education and reframing, gradual exposure, mind-body techniques. Again, all these things work together to actually help people with chronic low back pain. So pain education is an important thing. Now, what you need to always do is validate people, because sometimes when you start talking about these concepts, it can make people feel like you're telling them that they're crazy or they're making up. One of the first things I always do is tell you your pain is very real. It's just not necessarily your back that's causing it. And I'll have research that I can share with them. You can do newsletters. You can do little blog posts. You can do social media posts to your audience. You do Facebook posts for all I care that go to your gym, or do little in-house workshops for an hour teaching these people concepts where they can bring family members and really understand what is driving a lot of their pain issues. So again, we can talk about things like, we're not saying it's all in your head. We want to make sure they understand that. We're validating them, but we're also looking at, again, that pain is a protective response. So what is it protecting you from? Is it poor relationships? Is it poor boundaries? Is it work and stress? Is it the fear of your back and what that means? And again, this is all based upon a lot of research. This isn't made up. This isn't just being new agey. This is actually where pain science is going. Jessica, you've seen it, right? Quite a bit. If you're not addressing this component of pain, you're going to be limited in how much of an impact you can make. So we got to look at things. Do people fear their pain? Do they focus on their pain too much? They try to fight it. Are they frustrated? All these things are understandable, but these are driver behaviors of continuing having pain. So again, we're just trying to change people. Exercise can help, but depends upon one more really important variable: how you think about it. If you're going into an exercise program with the pressure of, I gotta get better, I gotta do this, I gotta find the right exercise, I just don't want to hurt myself, or what's going to give me the best result the fastest way, or how come I'm not getting better fast enough? That's going to drive more pain. If we focus on exercise and trying to build more enjoyment, getting people to explore what movements they enjoy doing and different types of forms of movement, and building more body confidence and giving people a sense of accomplishment with what they're doing and building social connection in the process, that's when exercise has a profound effect upon people's pain. So it's not necessarily the individual exercise, it's how we approach exercise and getting people to engage with exercise in a healthier manner. I think we ended right on time, Jess. So there's a perfect opportunity. We are launching our low back masterclass. It's a 6-week online masterclass. And I'll just, if you want to just tell a little bit about it.
Yeah, so this one's a little bit different than the ones we've done in the past, but it starts on June 12th. It'll run every week for 6 weeks. We are actually going to do this one on Friday afternoons, 3 p.m. Eastern Standard Time. And you do not have to attend. That is not mandatory. Obviously, it's nice that you attend and stay on track, but it will last 6 weeks. NASM approved CEUs, about 10 contact hours as well.
And we have a special opportunity in the next week. We're offering 20% off with code BACK20. You can contact us either at Josh at Ultimate Salmon Training, Jessica at Ultimate Salmon Training, or just go to our website, dvrtfitness.com, to find out more. But we're going to have a great opportunity. We're going to do tons of coaching, both on the exercise component, on the brain retraining component side for fitness professionals and rehab professionals as well. So with all that said, again, at DVRT Fitness, I know that's always a question people have. You're always welcome to email us as well. We're going to open it up here, I think, for some questions. Right, Jess?
Yep. Do you want me to, or do you want to read them?
I can read them.
Okay.
Even though I don't have my glasses. I should have brought my glasses. Yeah, so you can have lots of degenerative changes and have zero pain. In fact, surgery is the least effective, research shows, for people with degenerative changes. So degenerative changes on their own are probably not enough evidence for people to really feel like their back is the main driver of why they're experiencing pain or discomfort. What's your view of athletes training with deep back squats, which of course is weight on their back where their spine can handle in a deep squat, versus athletes training front squats with much heavier weights they squat? I think it's for a range of motion. Let me read that one more time. What's your view of athletes training with deep back squats, which of course is with weight that their spine can handle in a deep squat, versus athletes training back squats with much heavier weights that they squat with a shorter range of motion. Some coaches like the heavier, shorter range of motion squats for higher nervous system training. Any thoughts? While of course taking consideration of heavier short range of motion squats safer for older pro athletes. Thank you. Um, to me, honestly, I don't like back squats in general, especially for athletes. The potential issue with compression and shear forces on an athlete. Athletes are often fatigued, they're often injured, they often already have some, issues going on. A lot of research has shown there's no additional benefit in doing back squats versus front squats from a performance standpoint or a strength standpoint, but there is less compressive force upon the spine when you do more front load squats. I know that didn't really answer your question, but I'll change to the next part, which is doing, longer range of motion or shorter range of motion. Well, they both potentially have their own issues. If you can do a longer range of motion, that will build better mobility, and generally a good strength training program can increase mobility and flexibility if you go through longer ranges of motion. But that could be done in an earlier off season if you're trying to get to more specific types of training. Because again, a lot of sports, they don't require the full range of motion in their sport. You can do that as a progression when they're getting more towards their season. But I would not do that necessarily with back squats. I would go for more front load squats because again, the risk versus reward is just not there. I worked with several NFL and NHL players and even NBA. And I can tell you, the longer they play their sport, the more problems they have. So I want to get them in environments that they have the least amount of problems when they're doing their actual training. VAS is just a way to measure disability and function. So it's just a measurement technique in research. Osteoporosis clients are often told to only do strength training exercises seated. Advice I can give them. I think, Jessica, you can talk to this in a minute. I think it's always hard if a doctor, someone they trust, has told them to do something a very specific way. The way I would approach that from my perspective is I would start with what they've been told, because I don't usually get access to the physician, so I don't know why they were given that advice. I'll say, if that's the advice they have been given, we can start there and do certain exercises, but I would give them information over time to educate them on why standing is important, that they're going to get more weight bearing, that's going to be better for their osteoporosis. I think sometimes physicians think you're going to go right into heavy lifting, and that's not necessarily best, but I can start there because I also want to build their trust. They trust right now the physician way more than me. So again, I want to build their trust, and if they can do things without having pain and they are apt to want to do more and they trust that I have their best interests at heart, then I can start slowly introducing other forms of training, and maybe I'll have an opportunity to find out why their physician recommended them doing seated exercise, but I'll let Jessica answer her side as well.
Yeah, I mean, I haven't come across this, but I can kind of take a guess and I've seen it happen where people come back to the doctor maybe and go, oh, my knees are killing me. They had me do lunges and squats and all this other stuff. So the doctor just goes, hey, just do it seated, just do some seated exercise, simple, right? Like, let's not flare them up. So I think it stems from people not progressing appropriately. And maybe the patient goes back to the doc and says that therapy is not working, or, my training is not working, things of that nature. But I haven't really heard that before, but I do know if we're specifically talking about osteoporosis, when we have the hips and the knees and things, these individuals can get really flared up really quickly. So that might be where it's stemming from as well, is that people don't know how to appropriately regress or progress an exercise to accommodate for a lot of their limitations.
Yeah, and I think a lot of people miss, and this is something we're going to cover in the masterclass, a lot of options they have to progress people. They think they're going to go like from, seated or not being active to squats and deadlifts and things like that. And there's a lot of room for doing standing exercises that are not that. They can still be beneficial both for low back and other populations like osteoporosis. So did Josh say that people who don't feel pain live not as long? True. And what I mean is the ability to feel pain, not that people that are in pain. If you don't have the ability to experience pain, those people don't live as long. There was a movie that Jessica was kind of like, had to cover eyes with, where the main character couldn't feel pain. I think it was called Novocaine or something. And it was pretty gruesome, but like the whole idea is he couldn't feel pain. And it's a big thing too. It's like they have to be careful how they even eat, because they can't feel like if they bite their tongue or things like that. So it's people who can't experience pain. And that's a very specific condition. Those people tend not to live as long because pain is a protective system. Think about it. If I couldn't feel pain when my hand was on the hot stove, I'd burn my hand really badly. So pain is a protective mechanism. Do you incorporate working with pain, like pain reprocessing therapy? You talked about emotion stress affect pain. Do you address it or refer out? Depends. If I often can start people on the process quite a bit with a lot of the practices that we're going to be covering. People often come to us, for exercise. So I can do it I can see how receptive they are. And you got people that are more cautious about their backs, more worried about their backs. I can often do more of the brain retraining work with them right up front. People who are like, very type A personalities are like, yeah, I have some back pain, but it only bothers me blank, right? So they're more like want to get to working out and things like that. Then I can, backdoor it a little bit more subtly with them through certain mind body exercises that we'll do, just talking and teaching them about certain things, educating them, again, watching for language they use. So these are things we're going to all cover in the masterclass. It really depends on the individual, their receptiveness to the idea, what they're looking to achieve from the training. Some people, they have low back pain, but their main thing is they want to work out. Well, it's going to be more snuck in there versus people who are very fearful and are more receptive to like a more gradual approach to the training. Can you speak a bit more about on low back pain because of muscle guarding? Do you think those muscles would guard less if you worked on core stability because our core is getting stronger? Or do we need to get those muscles to relax a bit before doing the core stabilization exercise? For example, foam rolling before exercise. I believe a lot of use guarding, but I do some core stabilizing or go for a long walk and my low back pain flares. Thank you. I'll let Jess interject on this well. Muscle guarding can happen for a number of reasons. It could be that you just have a general subconscious fear of movement, like you're just worried about your back. And people that focus on their pain a lot will have more muscle guarding. So they're worried about when they're seated, they're worried about when they're standing, they're worried about when they go for a walk. The more you focus on the pain, which can be hard because it's like this thing disrupting your life, the more that you'll probably have this muscle guarding. So one of the things we do in brain retraining is trying to get people to focus on their pain less or how to work with their pain instead of continuing to be fighting with their pain. If foam rolling helps people feel less guarding, then great. But you have to understand that the number one thing that foam rolling and self-myofascial release does is it calms down the nervous system. So we can take that idea, anything that helps people calm down their nervous system will reduce their guarding. It could be breathing exercises. It could be gentle movement. It could be walking, assuming you're not going too far, too much, things like that. But remember, our brains are also prediction organs. So if you start to associate a certain activity, like bending over with pain, your body's going to guard more. Or if you associate that when I walk a certain distance, I'll have pain, your brain starts to predict this pain. So you want to do anything that helps kind of calm that nervous system to build safety with people who are experiencing this pain. Start with less and build up to more over time. I don't know if you want to say anything to that, Jess.
Yeah, I mean, if people have a ton of guarding or they come in with a lot of pain, then I do the feel good stuff, right? So we'll work on some deep breathing exercises. This is where modalities come in handy, right? Even though I know they're just kind of little band-aids, if I can decrease their overall awareness of their pain before we start some things, yeah, great. That's what modalities are for oftentimes. Or if I can do some hands-on, some manual work, kind of calms, like Josh said, we're calming the nervous system down a little bit, and then they feel a little bit safer to try different exercises or begin with core stability and move on to strengthening. Every single patient is different. I don't have any patients that do the same thing. So I adjust for the moment they walk in the door and kind of get a feel for where we're at with them and kind of go from there.
Yeah, I think everyone wants a formula to give everyone.
Yeah.
And that's where you have to have an understanding of these concepts, principles, and you have to have kind of a system to work with because people are going to be so individualized. You need to know who's going to get more of this and how much and things of that nature. And we are going to cover a lot of that and help people give a better system to what they're doing rather than looking for, I need a menu and I need someone to tell me the recipe. So I just follow this for everyone. It won't work. It'll work for some people. It'll not work for a lot of people. If your low back pain is equivalent to hip pain, I always recommend that you get a good workup by your physician. Make sure that there's not any type of radicular pain, meaning a nerve compression or something going down your leg, or there's not something going on with the hip itself. It's always good to find out. So something you could do proactively, and I don't know if Jessica can, give any other advice. When you are sitting down with the imaging with your doctor, ask them things like, what does this mean? Is this the cause of my pain? If they find that you have a little bit of a labral tear, in your hip, you may or may not have pain, but you ask, do you think this is contributing to the pain I'm experiencing? Ask some questions in regards. You have to be an advocate for your own health in a lot of these different cases. I don't know if you have any additional advice, Jess.
I think we might have read that. I think she was asking, is this the same when it comes to like back pain and stuff? So all chronic pain can be kind of addressed similarly. It just doesn't have to be chronic low back pain. We can kind of take a look at if someone's got chronic knee pain, chronic hip pain, and so forth. It's kind of the same process.
Can we download these slides? You're free to email us later on. We're happy to give you guys the slides. Happy to do so. What do you do in situations where clients have chronic back pain with no specific diagnosis and their physician, who may not be current on exercise research, scares them about weight training or tells them not to lift weights at all? I still get this in my facility from time to time. Guess what I do? I don't lift weights. I know this may shock people.
Yeah.
We don't lift weights. Because again, you have the physician that, again, you don't get an opportunity to find out exactly what they said or what context they were talking in. You're getting the telephone game a bit. And you're getting the client who goes, I trust this person. This is the doctor. And if you try to go against them, guess what you're probably going to invoke? A lot of fear, a lot of apprehension, and that can drive them pain. And as soon as they have pain, they'll be like, see, my doctor was right. I shouldn't be lifting weights. And it only takes one rep for that to happen, right? So we'll do a lot of mind-body training. This is where, again, we have our own system of doing this, but you can integrate yoga, Tai Chi, Pilates methods in for a lot of people. This stuff still builds strength, and all those systems have been shown to be actually very effective in reducing low back pain, but they're not lifting weights. And I think a lot of times us as coaches, we get really limited in what we can actually do. We have some lifting exercises, but we don't have enough movement systems that we know. The more movement systems you're aware of, the more options you have. We don't have to lift weights, right? We can do other movements that don't invoke that fear, that gains our trust, that if they start decreasing their pain, they may then move to being able to lift weights with confidence and feel very safe about it. Would you agree, Jess?
Yeah.
All right. I am a trainer with L4, L5 spondylolisthesis. I have been putting off surgery for many years. Aside from exercising, I do acupuncture, physical therapy weekly. I stretch, I use Hyperice, I foam roll it. It is getting worse and I'm running out of options. Any suggestions? I mean, the first thing I would do is always get a new imaging process done and go over it with your doctors. I mean, Jessica can talk about this more, but I think comparisons are really important. Jessica, can you maybe explain what that is and why that's important?
Yeah, I mean, if you think your symptoms are getting worse and worse over time and you haven't had updated imaging, then yes, go back and get imaging and then you can compare it to, I don't know, the one that you had 5 years ago. If it's still the same, then I wouldn't really jump at surgery because nothing structurally has changed to warrant an increase in your pain. So I would probably look at, what type of exercise are you doing? How consistently you're doing this exercise? How consistently you're kind of doing check-ins when we're talking about chronic pain? Does that pain fluctuate throughout the day? So kind of going through more of that pain reprocessing therapy to kind of make sure that, we're not looking at that type of pain as well. But I think there's still a lot that you can try to decrease a lot of your pain and symptoms, but I don't know your full history. I don't know the type of pain. I don't know your symptoms and things like that.
I would tend to, assuming again, the imaging didn't show anything significantly different, err on the brain retraining side of things. So a lot of times people with chronic pain, they're constantly in an intense way trying to fix their pain. They do 5 million different things. I did a consult with a fitness coach who she was struggling with low back pain for many years. She had some surgeries actually done. And I asked her what she was doing for her pain and she rambled off a list of 15 different things. So that meant she was, kind of compulsive. She was constantly fighting her pain. She was frustrated. All the things that drive more pain. What we started with was her actually doing less things and having less intensity behind these things and changing, again, how she was viewing her pain and being able to relate to it differently. As Jessica said, a lot of times, if your pain is fluctuating through the day, that's a sign it's actually the neuroplastic, that brain processing issue, not necessarily your back itself, that's driving a lot of pain. So you can go through that fit criteria, that things we were talking about, is it functional, is it inconsistent, is it triggered? And if you check off more of the symptoms, you can have more confidence that it's probably the brain retraining that you need, and fortunately not surgery. Spinal surgery typically only works well if you're having radicular symptoms, like things down the legs. It doesn't work as well if it's just kind of this generalized spinal. So you may want to look at those aspects, and gain that comparison. Imaging will be really helpful because, again, as Jessica said, if there's not a big difference between the two, I'd probably definitely stay away from that and more look at how are you approaching your pain rather than, like, again, looking at the area of surgery. We'll give a little more time here. We just got a lot of questions. I know back pain always gets a lot of questions. I lost my ability to segment my spine, specifically in spinal flexion. I'm 1 year after disc bulge. My back moves like 1 unit from L5 to T6. Well, that would be hard. I don't know what that segment is. Maybe you mean S1? I don't think there's no, that'd be.
Oh, they're going up the other way.
They're going the other way? Okay. I just need
Bottom to top.
Okay. I try to gradually apply flexion. It does have uncomfortability, so it leaves me second guessing if I should keep flexing to try and open this back up. It depends really what you're doing, and again, the intensity that you're doing stuff with. If you go in there with the attitude, I'm going to try to fix my back, or I got to get more flexible, you're probably amping up that nervous system and be more protective. Look at the type of drills you do. You may want to start with something really subtle, like a cat-camel type of drill, where you're just learning in a very stable environment how to move that spine very segmentally and not try to force it. And whatever you are able to get at that time is good enough for at that time. And learn to get more and more comfortable in a more progressive means. You can sort of work with breath work, but not using breath work like, I gotta get calm, I gotta get calm. That's like one of the major mistakes people do with breath work, is they are trying to achieve calmness rather than just focusing on what the breath feels like. So again, the more you can sort of do things to downregulate that nervous system as you're doing those movements, the more apt you are to get more movement out of them. I'm fused from C2 to T2, from L4 to S1, and I can fully flex. Now, it does have some compensation, right? I can't flex the spine segments that are fused, but I can fully touch my toes. But if I go in there and I'm like, I gotta touch my toes, I gotta touch my toes, oh my God, am I gonna get there? And I hold all this tension or all this worry or this concern, or I try to accomplish this in a very intense way, it's gonna reduce my ability. So you gotta start in the right environment, you gotta do it in a more relaxed manner, and you gotta be less outcome dependent. Just try to build it from one little bit at a time and see if you just put less expectation upon it, that you can get more results from it. For clients with herniated discs and micro tears in the lower back, what exercise and stretching would you avoid? Anything that hurts?
Yeah. And it can take trial and error. I mean, it takes me a couple sessions to figure out what's going to work and what's not going to work. So don't think that you have to jump in day one and know exactly what's going to work for someone. I think there's a lot of pressure that people put on themselves to do everything just perfect and everything's going to work out. I mean, there are several times where I'm like, that one's not going to work, and that's fine. You just move on. Just say, we're not going to do that movement next time, and find the things that start to work. I know that's a really broad answer, but anything that causes pain is out for now.
I mean, also do things like also know, what are they scared of certain movements?
Yeah.
So if they are fearful of spinal flexion, I'm not starting with that. We're not doing that for a while, right? We may do things that keep them in positions and postures they feel less threatening, things they feel more capable of doing. I don't do a lot of stretches where they're clenching down, and if it's the most intense thing they do, I want to do it in a more calm, relaxed manner. That's why we teach, and we'll be teaching during the master class, our myofascial integrative movement work, which is more mind-body, where we're using breath work, we're using more gentle movement, and again, working in ranges of motion and patterns that people feel comfortable with, building that movement competency, as well as improving the tissue elasticity. And those things together get people to actually engage with the stretching more effectively, and they'll get more out of it than if you're trying to fix their pain all the time, or they're trying to get the stretch really intense. That's not what we want from any type of stretching program. I heard you say this class is a bit different than the previous low back master class. I've taken the previous low back class for this one. So, okay. Sorry. We've offered other low back pain classes in the past. Yes, this will be very different. We're actually giving not only 6 weeks of webinar information, we're going to be giving over 6 hours of video coaching that you guys can go over at your own time. All the recordings will also go out to people. So if you can't make the classes, you do get those video recordings. But yes, we'll have more handouts, we'll have more video coaching, and we'll be covering some more topics in some different types of depth. So we'll spend more time doing some of the brain retraining training. We'll be going over different stretching techniques and also different lifting cues and systems use. Thoughts on aerial yoga fitness for back health? If people can do it and they don't have pain, great. I don't know if it's specifically ain't going to be any better. Some of the movements, if people don't handle extension very well, or I don't know if they I don't know enough about aerial yoga. I don't know if they get traction that might aggravate certain people. So like most things, I would start slow and small and see how they do with it. If they find it fun, then that's going to help our cause. So it can be a tool that we use if they find it enjoyable. I don't know if Jesse, you have too much about that as well.
I'm not too, I mean, I know of aerial yoga. So if people enjoy it and they're finding that it's helping, then it's great. But again, start slow, try a class. If you feel fine, then keep going. But like Josh said, it can get you into some positions and postures that if you have like pretty flared up low back, I probably wouldn't start it off the bat.
Yeah, again, I think it needs to be progressive. If I
Yeah.
if I have one big criticism of a lot of the mind body practices of Pilates, yoga, and Tai Chi, they're not made to address things like low back pain. That wasn't their original intent. So you need to change the way they're sort of taught and introduced to many people because, again, they need to be more progressive. They need to think about these other factors because, especially with something like yoga, someone may feel like they should be able to do this very extreme pose or stance or something like that, and they may push themselves beyond their limits, get a flare up, and then feel like they can't do this thing rather than doing it more progressively in nature.
So I'm going to let you finish the rest of the questions. I do want to say thank you to everyone, but I have to jump out. And I
No,
do
everyone's gonna
appreciate
lose
everyone.
interest.
No, there's a few questions left, but thank you guys. And I'm going to hop out.
Yes, it was a little bit fast, and so I apologize. We will be sharing the recording for people. So if you're interested, just keep in contact with us. We'll be sharing the recording. You guys can go through it. It's a lot of information in a short amount of time. We just want to stimulate your interest and understanding that there's a lot more than just exercise to helping people with low back pain. And the name of the studies you showed, I would like to watch again. So yeah, if you guys, email us, but if you go to our website, we'll have the recording posted in the next few days. So again, you can definitely stay in contact with us. All our information was there. You can go to dvrtfitness.com if you want to email us. There's a contact and you'll get to us. I don't know if Perform Better has time to put up on the app quite yet. That's something for Aaron and Chris to let us know, but we'll be sharing. We usually share the recording when it's available. Do you ever refer out to an acupuncturist to help with downregulating the overactive sympathetic nervous system and help boost the parasympathetic? If people are open to it and like it, the challenge with things like acupuncture is that it's not necessarily consistent enough in showing that it helps reduce back pain to, again, it's going to be another expense to my client. So oftentimes what I'll do first is I'll try to do things to downregulate that nervous system. We'll go over behaviors that they're doing to fuel that sympathetic nervous system. If they really like acupuncture and they are, wanting to do acupuncture, I'm all for it. But just like anything else, like massage or chiropractic, I don't want them to think there's something magical about it. I want them to go in it to enjoy the experience, to just try to relax their bodies, just to have time to themselves. One session's not going to fix them. We already know that. So again, just try to be very positive about it. Try to enjoy the experience. See if it's something that they find useful in helping them feel better. So lots of times we like to find lots of tools that make people feel better. It could be a hot shower or a bath. It could be getting a massage, right? All these things are great tools just to help downregulate that nervous system. If they love acupuncture, cool. If they don't believe in acupuncture, then no, because then we get the nocebo effect where they're less likely to get a positive benefit. I don't know if people can speak, Aaron or Chris. I know someone has a question they want to speak, but I don't know if we have
I
that
don't
ability.
think we have that option available. I don't
Yeah,
think we
no,
ever
it's
set
it's
that
not
up.
available. The mics
Yeah,
have
you're always
been turned
welcome to
off.
email us if you like to
Sorry.
do that. Yeah, you're welcome to email us if you have a question that you think is a little hard to ask. My doctor is recommending steroid shots for my low back pain. What do you think? I can't make an opinion on that, not knowing what's going on with your low back pain or why they're recommending steroids. I don't want to make a medical call that I don't know enough about. You're always welcome to ask your doctor, like, why are you recommending steroids, and what else can we do? But I can't comment on that responsibly. All right, guys. Well, that's everything. Again, if more questions pop up, you're always welcome to reach out to Jessica and or myself. We're always happy to answer more questions. And I really want to thank Aaron and Chris for giving us this platform and opportunity. We're excited to be seeing them at the summits this year. I know the summits are coming up fast. I'll be at Chicago and Long Beach. Jessica will be at Province in Chicago. So it's a great opportunity if you guys have more questions to come up, and we would love to talk to you about those things. So thank you to everyone who attended, and a special thank you to Chris and Aaron. Really appreciate it.